quick dry run of the opening. So be obliged. Are we go?
We're ready. Thank you.
Excellent. All right. So I'll start from the top. That way we've got it on the recording, and you don't miss anything that I said, because this opening was gold. I want to thank everyone for coming today. I want to thank in particular Mental Health America in Delaware for all the work that they've done in increasing access and resources for mental health care in this country. By way of introduction, my name is Dan Saddawi-Konefka. I'm a physician in Boston. I work in the intensive care unit by my subspecialty. I also do care in the ORs as well. Relevant to the talk today, I'm also the program director for a residency. That means I look after a bunch of physicians in training. It's a 4-year program that I look after. I've got about 26 residents per year, so just over 100 residents in total. Before we move forward, I want to let you know that I do not have any relevant financial disclosures. We're going to be talking about barriers that physicians experience in accessing emotional and mental health care. So though it's not a financial disclosure, I am involved with the Emotional PPE Project, and that is its mission, to decrease those barriers. I also have received treatment for depression myself, and I have lost friends and mentees who are physicians to suicide. That is my background, and I'm sure that those experiences color my perspective. My goal today, though, will be to give you an informative and unbiased presentation on the barriers that physicians face when considering seeking mental and emotional health care. And I suspect that it will be a little bit surprising if I don't know if you heard me on the dry run, but I think a lot of folks assume that because physicians are in the know, they have access to resources and people that, and they know the benefits of care, right? That maybe this would be not a problem for them. Turns out that's very, very untrue. It's a big problem for a lot of unique reasons. So what we'll talk about today is first the scope, the state of mental health amongst physicians. Next, we'll explore the current barriers that physicians face when considering accessing mental and emotional health care. We'll talk about the Emotional PPE Project and how our organization is working to decrease these barriers and provide support to physicians and other healthcare professionals in ways that hopefully circumvent these barriers. And finally, we'll discuss the work that needs to be done. And a secret hope is that some of you will feel very aligned with the work that we're doing and want to join the team. By the end of the presentation, I hope to have provided you with a deeper understanding of some of the unique challenges that are faced by physicians when it comes to accessing emotional and mental health care, and how we can work to overcome those challenges. I am a big fan of giving the takeaways up front. That way, you know what we're going to be talking about. You know, I'll be able to tell you what I'm going to tell you, and then I'll tell you what I told you. So hopefully that's safe. So first, mental health needs amongst physicians are significant. The demanding nature of the job, the long hours, the high stress environment, the loss of life, the suffering that we see all contribute to an increased risk of depression, anxiety, and suicide amongst physicians. Second, very few physicians seek help, and those few that do only do so as a last resort. Third, though you might expect physicians would have easier access, there are a number of unique barriers to help seeking that makes it difficult for physicians. Some of these include career impact, stigma, culture, and logistical things like time, cost, and access. Fourth, the Emotional PPE Project provides access that circumvents a lot of these barriers. Through our research and advocacy arms, we also help take down some of these barriers. There's going to be a lot of work to be done, but I want to emphasize that progress is possible. I'll show you some of the small wins we've been able to obtain, and hopefully some of you will feel motivated to volunteer with our group or with other groups. There are lots of people who are contributing to this great cause. All right, so let's start by talking about the scope. So the incidence of mental health symptoms is alarmingly high amongst physicians. I'm going to talk about pre-pandemic. The pandemic's made things a lot worse, but before the pandemic, rates of depression and anxiety were upwards of 30% amongst physicians, and rates of post-traumatic stress were approximately 10%. Let me give you some framing for that. If you look at adults in the United States, 10% have diabetes. So think about people that you know with diabetes. The incidence of PTSD amongst physicians is the same. The incidence of depression and anxiety is 3 times that. Physicians are definitely not alone in this. The rates of depression and anxiety here are actually not that far off from others in the workforce. What's notable, though, is that many of the drivers of these conditions, things like socioeconomic disadvantage, lack of resources, etc., are not typically seen in physicians. They're in many ways a very privileged group. That suggests that physicians must be at high risk for other reasons. Additionally, rates of depression in physicians and anxiety are going up and have been for a while. Systematic review from 2015, so again pre-pandemic, suggested that in a couple decades that preceded that, these rates are increasing at about 0.5% per year. Early data since the pandemic suggests that these rates are rising substantially more dramatically. Sadly, the consequences of this are profound. Physicians complete suicide at a rate 44% higher than non-physicians. It's just over 1 physician a day in this country loses their life to suicide. The reasons for this are incompletely understood, but may be due to higher rates of psychological distress, access to more lethal means, or larger barriers to access. Now, I suspect that I don't have to hammer this point home too hard with this group, but treatment of these conditions is imperative because it's effective. It works for the treatment of depression, it works for anxiety, it works for PTSD, and it works for decreasing suicide attempts. So it's gotta happen, but it doesn't. Fewer than 1/3 of physicians with mental health illness seek help. And if you look at the proportion of physicians who have things that maybe fall short of diagnoses, even less. So why is that? What are the barriers? The barriers are many, and unfortunately complex questions often don't have a clean or easy answer. Researchers who look into this to try to inform the answer to this question tend to employ survey-based methods or qualitative research. So I've spent a lot of time reading through that literature and talking with other advocates in the field, and I want to share with you a framework of 4 buckets, 4 areas of barrier that I think about. These are not mutually exclusive, they spill over each other, but I think it's a nice way to sort of frame up the issues. The first is the perceived negative impact that receiving care can have on physicians' careers and employability. It's not risk-free. Second, and possibly most importantly because it drives so many of these others, is the specific stigma role that physicians have. And I think that's honestly enabled to a great degree by sort of an inflated sense of being able to care for yourself if you're a physician. And the final one relates to the logistical barriers of time, cost, and access. So we'll spend some time going through the data that suggests that these are each issues. First is career impact. So this is one of the most commonly cited by physicians in terms of barriers to seeking help. I'm actually going to say there are some real career impact issues that arise. I'm going to lump those in with perceived career impact, because when you talk about what actually drives behaviors, it's the perceptions that people have. It's not always the realities, even though those overlap heavily. This barrier relates to fears that future disclosure of mental health conditions or seeking help for mental health conditions may be required and may limit their employability. It also relates to the stigma of mental health in medicine and the fear that having a mental health condition will eliminate some career opportunities. So let's first talk about licensing applications. If you're a physician and you want to practice anywhere in this country, you need to be licensed. You have to apply to a state medical board to get your license, and on those applications, they ask questions. Turns out Questions related to mental health diagnoses are unfortunately common on applications that physicians complete. These questions arise on licensing. They also arise in a lot of different areas, and I'll share that in a little bit. Let me show you an example of a question from a licensing application. This was pulled from 2020, so this isn't the 1980s we're talking about. This is 3 years ago. Have you ever been diagnosed with, treated for, or do you currently have? And there's a list there. It includes things like bipolar, hypomania, schizophrenia, depression, even seasonal affective disorder. And it's not, does this impact your care of patients? Have you ever had one of these diagnoses or sought treatment for one of these things? Why are they asking these questions? Well, the implication is that they think they need to keep patients safe, and if you have one of these things, you're not going to be safe. I'll go on to say that in this particular application, there was another section of it that actually said that everything that you answer in this form becomes public. It's public disclosed. There is no evidence that asking questions about mental health or licensure improves patient safety or outcomes. It's well intended. I don't think the people who created these things are trying to hurt physicians, but I think they do. And to be honest with you, if you think about it, if this is actually discouraging people from getting help, it could actually be hurting patients. In the case of states that ask these questions, it turns out there is risk of harm. I want to mention that these questions are actually disallowed under the Americans with Disabilities Act. You're not supposed to ask about illness without impairment. You're not supposed to ask about things that aren't current. In 2017, Derby and colleagues out of Mayo looked at state applications and actually found that 2/3 of applications were inconsistent with the ADA. They also found that in states that had such questions, physicians were significantly more reluctant to seek care. So no evidence of benefit, definitely evidence of harm. In 2018, so a year after that study came out, the FSMB is the Federation for State Medical Boards. They're an umbrella organization that gives advice to boards in different states, came out with a series of recommendations to support physician wellness. And we picked up some research from there. So here, they had 10 recommendations overall. There were 4 that were actually evaluable on licensing applications. 1, you only ask questions if it's about impairment, not about illness. 2, you only ask about things that are current. 3, you offer what's called safe haven non-reporting. What that is basically, if you're a physician and you're working with what a lot of states have called physician health programs, getting care for your conditions, you don't have to disclose a thing. You can answer the question, no, I don't have anything you need to know about. That's safe haven non-reporting. And you offer supportive or normalizing language. So we got all 50 initial licensing applications. We also got Washington, D.C. and 3 territories. And we looked to see how consistent were they. This was in 2020, so 2 years after these FSMB recommendations came out. And every state got a score from 0 to 4, 4 being you're consistent with all 4, 0 being you're consistent with none. Before I show you the map, I'll tell you that 28% of applications, just over a quarter, asked about illness independent of impairment. 24% asked about conditions independent of age. So things that were more than 2 years old. Less than half, only 44%, offered safe haven non-reporting. And offering supportive or normalizing language was only done by 15%. This is the overall report card. There was only 1 state that was consistent with all 4. There were 5 that were consistent with none. Beyond the recommendations made by the FSMB, we noticed a bunch of other embedded barriers. And that's the focus of a qualitative study that we have currently ongoing. I'll share a couple of examples. So in some states, and I alluded to this earlier, applications may become public record. So you give us your medical records, it's now for everybody. There's also what we call the stigmatizing structure. And this is where questions that could relate to mental health disclosure were embedded in sections that otherwise focused exclusively on immoral, unethical, illegal activities. So for example, have you ever committed a misdemeanor? Have you ever committed a felony? Have you ever been dishonorably discharged from the military? Do you have any mental health conditions that could impair care? Again, I'm sure it's not their intention, but the subtext, the messaging there is very, very clear. They're lumping all of those things together. Applicants may also be asked to produce health records around any leaves of absence. In other words, what we see on the licensing application is really the tip of the iceberg. If you answer yes to anything, you can be made to follow up with a whole bunch of things. I'll give you some personal examples. I know one of our board members on the EPPE was made to sign a blanket waiver to provide access to all of their medical records. I've had two residents. These are residents or physicians in training. They're not practicing by themselves, so they're looking for what's called a limited license. The stakes are substantially lower because all of their care is under direct supervision. Neither one of them had any issues with impairment. They did, however, take leaves for personal reasons. They were made to appear before the board in person to answer questions about their leaves related to private health matters. Again, neither of them had any issues with impairment. In both cases, my trainees were incredibly stressed. Think about it, if you don't get your limited license, you don't get your license, that's it, you're done. You cannot practice. Both of them hired attorneys. And it was all for naught. I mean, there was nothing to find there. Both of them got their limited licenses, but the experiences were incredibly traumatizing for them. So the notion that you could just seek care, carefree, or take a leave to address something you need, so it's a little bit of a fairy tale, unfortunately. The fear of career implications extends well beyond licensing applications. They're the most studied because they're the most accessible, but it comes up in a whole host of things where disclosure might be required. Things like credentialing applications commonly ask about conditions, and credentialing applications are, so you have your license, now you want to work in a particular health setting, so the health setting needs to verify that you can do what you say you can do. So as a program director, I get a lot of what are called verification forms for the trainees who trained under me. Man, they ask a lot of questions. I'll show you an example on the next slide. But it's also things like commercial insurance credentialing, which often requires HIPAA waivers from all employees, malpractice insurance. And there's also the fear that, hey, if something goes wrong, even if I've never had to disclose anything, maybe under legal discovery, I'll have to talk about this and it'll be held against me. And again, these are all related just to employability. Can I practice? It's got nothing to do yet with career impact opportunities. That is also an issue, and I'll get to that on the next slide. Here's an example of a question that I took off of one of the verification forms that was sent to me. Does the physician have any condition that could result in impairment? It's a hypothetical impairment. I look at this and I kind of laugh. I mean, like in my mind, I'm thinking, well, they're human. So I guess so. I have a standard answer now. I actually write this. It's a little bit small. I'll read it. Let's see. I don't want to mess the mic up. Regarding the question about mental and physical health, Dr. So-and-so has had no issues with impairment. As an important aside, asking about hypothetical impairment, quote, could affect, is at odds with the spirit of the ADA and has been discouraged by the Joint Commission. I give them a little link that they can look at. Please revise this question. Thank you. Feels good to do that, I'll tell you. Physicians also fear they will miss out on opportunities if they're labeled as having a mental health condition. I'll talk about stigma in a little bit, but I'll note that this fear is real, and it drives reluctance, even early on. In studies of medical students and trainees, approximately 1 in 4 cite impact on future opportunities, things like matching into residency or fellowship, as primary barriers to help seeking. Dr. Carrie Lubitz, this is her right here, gave the presidential address for the Association of Academic Surgery. She is an exceptional physician, an exceptional leader. She's had a career outside of medicine. She actually is a tennis professional, played at Wimbledon 5 times. I recommend that you check this out at some point. Maybe scan the QR code and look it up sometimes. It's one of the bravest speeches I've seen in medicine. In this speech, she talks about her history with mental health and mental health challenges that she's experienced. And for our purposes here today, I want to highlight something that she said right at the beginning. I know that giving this address today will change my career path. There will be jobs that I'm not offered. There will be doubts as to my abilities. There will be people who see me as weak, emotional, and damaged. So let's talk about stigma. Stigma and medical culture, I think, is at the root of many of these things and promotes many of the other barriers. We were talking just about this before I came up here. There's this hero narrative in medicine. And I think this, unfortunately, though I think well-intended to celebrate the hard work that folks are doing in healthcare, I think it contributes to this invincibility complex, the idea that heroes don't need help, right? So why should I? In survey studies, 96% of physicians agreed that doctors should portray a healthy image. The way that this gets translated into barriers for self-care, I'll read you a quote here from a qualitative study. This is from a physician. Doctors feel they shouldn't be sick. You don't want to go and see your local psychiatrist in case one of your patients is sitting beside you. This stigma is reinforced by beliefs that are unfortunately common in medicine. In one study of over 1,600 physicians in England, they responded to a survey that included questions about their perception on whether certain beliefs were common in medicine. The majority of respondents agreed that the following statements were common beliefs amongst physicians. A doctor with a history of depressive illness is less competent. Suffering with depression is a sign of personal weakness. Many doctors think less of doctors who have suffered from depression. Notably in this study, physicians who perceived higher degrees of these stigma in medicine were they themselves less likely to feel safe seeking help. So the result of this is that physicians hide their weaknesses and are reluctant to seek care. In a survey of trainees, 58% responded that they would be reluctant to seek care because of fear of being labeled weak, unable to handle the pressure. 48% feared that they would get stigmatized and labeled as having a mental illness. And get this, in a study of psychiatrists, this is 400 psychiatrists. Talk about proximity and understanding to what the benefits of therapy could be. 85% reported they would be reluctant to share mental health diagnoses with colleagues. So that's the state of stigma amongst physicians for mental health care today. The third barrier relates to resistance to external help. This encompasses both denial and actually ambivalence to the value of good mental health and resistance to taking on the patient role. So it turns out that for a lot of the reasons we've talked about, poor emotional self-care, poor self-care in general is kind of normalized in medicine. I remember when I was training, let's say about 15 years ago, which is not that long ago, there was the old adage about, if you're sick and you cough up a lung, okay, shove it back in, get back to work. That seems to go deadly for emotional self-care because it's never modeled by mentors. Instead, running half empty is the norm. And help is only really encouraged when people are depleted, close to the breaking point. The problem, of course, is that half empty should not be the norm. The consequences of this is that physicians who are unwell look around and think, well, compared to my peers, everything seems fine. Nothing's wrong with me that's not with them, so why would I seek help? The more extreme result of this is complete ambivalence or apathy about the value of good mental health care. In one study of physician trainees, 5% actually said that they don't even think good mental health care was useful at all. Sorry, that they didn't even think good mental health, not care, just good mental health was useful. And if their role models are productive and seem successful and all that stuff and have poor mental health, why would they think anything else? Now, even if physicians feel that help might be beneficial, that maybe they have something that needs to be addressed, there's still great reluctance to seeking care, which is enabled, I think, by, I don't know, maybe we call it egos, the sense that they've gone through training, they can actually just take care of themselves. So in one study, 7.4% of all responding physicians, this is not physicians with known diagnoses, this is all physicians who responded. 7.4% reported that they had self-prescribed antidepressants. If you remember that study that I mentioned about the psychiatrists, the 400 psychiatrists, in that same study they asked whether they would seek formal professional advice if they had mental health illness. Fewer than half said they would. Over half said that they would prefer to seek informal advice, self-medication, or no treatment at all. So the last barrier has to do with time, cost, and access. And I will note that this is a huge problem, not just for physicians. This is a problem for anyone seeking mental health care. There are, for some particular reasons, some unique challenges that arise with physicians, and that's what I'll speak to now. So the average practicing physician works over 50 hours a week. A quarter of us work more than 60 hours per week. In addition to contributing to psychological unwellness at baseline, this lack of time itself is a barrier to help seeking. It's actually cited by 3/4 of physicians as the primary barrier to help seeking. Physicians have also had an incredible sense of duty with high concerns about what their absence means for their colleagues, their patients, or their system. Taking time off of work does not seem viable. 3/4 worry that if they did that, they would let their colleagues or patients down. The mantra is actually ingrained pretty early on that that's just not what you do. Trainees express fears that if they do that, they'll actually be, it's half of trainees said that they would be worried that they would be accused of unprofessionally skipping out on work on the pretext of feeling stressed. When it comes to access, an additional challenge for physicians stems from the confidentiality concerns, the concerns that I don't want a paper trail, I don't want this to have any impact on my career opportunities or for future disclosure. And we talked about those, but what that means in terms of access is that many coworkers or employers, they want to hide this from them. So in one report of trainees, 55% of them said that if they were to seek help, they would need to find a provider outside of their institution. When you don't have many hours to find help and now you're looking somewhere else, this dramatically decreases access to care and increases the time associated with seeking care. It also increases cost. And the reason for that is that a lot of physicians end up connecting with therapists who are out of network. And even if they don't, some physicians choose to pay cash so that there's no insurance record. So let's recap what we have so far. High rates of mental health symptoms and suicide among physicians are deeply concerning and require action. Seeking professional help for these conditions is effective and crucial. But few physicians seek help. And many of the known barriers fall under concerns about potential impact on their careers, powerful stigma, a culture of resistance to external help, and challenges with logistical concerns like time, cost, and access. We can change this. It's not easy, but the good news is that there are a lot of people who are dedicated to changing this. So I'll tell you about our small piece that we were able to contribute with the Emotional PPE Project. The Emotional PPE Project is a 501c3 nonprofit organization. We started in April 2020 in response to the need for professional emotional support in healthcare workers impacted by COVID. Our mission is to reduce barriers to accessing mental health treatment for healthcare workers. Not just physicians, all healthcare workers. Our vision is a world where healthcare workers access mental and emotional health support without any hesitation or worry. The notion that you wouldn't even think to mention it. If you stopped for gas on the way home, you wouldn't say, hey, here's the thing, and like I needed to get gas. It's just, it becomes just a, yeah, of course, the car was empty, you need gas. To date, we've approached this with a two-pronged approach. One is to help immediately, and that's through a directory of online volunteer therapists. And one is to help the future, and that's through research and advocacy. So I'll share some of the things that we've done in each of those. So to help immediately, we have a directory of volunteer therapists who offer no cost, no paper trail, confidential therapy to any healthcare worker in need. This was of tremendous importance during COVID when depression, moral injury, burnout, post-traumatic stress symptoms were at unprecedented levels. We have over 700 therapists, which includes therapists in every state in the country. And that's important because you need to be licensed in that state to provide care as a therapist. Now, how many healthcare workers have we helped? It's actually we talked about early on, like how do we track this, because we need to do that. But if you think about it, one of the barriers is that your name might be on a list somewhere. We were very committed to not creating any barriers. So we actually don't collect any information about anyone who visits our site or any information from them about if they contacted a therapist. So our metrics are imprecise. We only know of use of our therapists if the therapists reach out to us and tell us, I got a use. They don't give us details about the person, but I got a use. So it's imprecise. I can tell you though, based on those reports alone, we have helped over 2,300 healthcare workers. That's over 2,300 people who accessed help that otherwise was not as easy or didn't seem accessible to them. On occasion, a healthcare worker reaches out to us by email or through social media to share some of their stories. With permission, I want to share a couple of quotes from two healthcare workers who used our services, and rather than having it read in my voice, I'll put them up there and let you read them. There is a screen in the back if it's too hard to read. Looking this way. I want a world where we don't get testimonials like this because they're not needed. In order to create that world, we got to make change. And that's the second arm of our organization, research and advocacy. So I mentioned earlier that initial paper that we published in JAMA about consistency with FSMB recommendations. The one where over a quarter of state licensing applications asked about illness without impairment and asked about things that were over 2 years old. It's been 2 years since we published that paper. We have another paper under review now, and I want to tell you about some progress. So in those 2 years, compared with where they started, 8 additional states now appropriately limit questions to impairment, not just asking about illness. And 5 additional states only ask about current conditions. This is small, but great. It shows that change is possible. We've also partnered with many different organizations to promote the conversation and push for normalization of mental and emotional health care groups like MHA Delaware. Some of our publications and media outreach endeavors are shown here. But there's a lot of work yet to be done. So I want to tell you just briefly about some of our strategies going forward. So first is continued and expanded research projects. We have 3 projects underway. One is a revisiting of the 2020 data to show the improvements that have come in the work that's yet to be done. We also have the qualitative piece that's looking at the other barriers that are embedded in applications, things like the stigmatizing structure or the public disclosure of mental health records. And then we have one additional piece. It's a scoping review looking at all the literature on barriers to help create a framework. The framework that I gave you today is one that I think will emerge from that, but we haven't finished that review. I want a roadmap basically for advocates so that you can see here are the barriers, what are we going to go after, let's divide the work up and get it done. If we changed all licensing and credentialing applications and all of those other things, we would still have a problem. And it's because of the stigma that exists. I'm heartened because actually I think new generations and folks like you all are helping change the narrative around mental health conditions. One of the things that we want to do is make that easy. So we're working on a series of toolkits, workshops, trainings. If you're interested in doing this for your group, you don't have to recreate the wheel. It's plug and play. Things like how to role model vulnerability so that people can actually see that it's not an unusual thing to do. Further down the line, our hope is to come up with entire programs that we will offer completely for free. None of this is to try to get money. Where we partner actually with training programs. So we partner with med schools, with residency training programs, with nursing training programs, occupational therapist training programs, and so forth. Because I think the way that you change the stigma, it's really only going to come by normalizing it when people start. If you look at rates of depression and burnout and moral injury, if you look at physicians as they're just before they start med school, they actually do better than age-matched peers. But within months, they're worse. Suicidal ideation in training throughout early in med school and training and early in physicians' careers is actually above 10%. So I really think that that's where we have to start doing some hard work. We would love your help here. If you're interested in helping spread the message, please follow us on social media, add responses. If you want to contribute in some other way, just be open and vulnerable with people. I think the more people that understand that these things are not they're not weird for having these conditions, I think the better we'll be. We have a very, very lean budget. We pay for some insurance, and we have 2 part-time coordinators. The great news is that we don't have to spend a lot of time fundraising. The other great news is that if you're interested in donating, even a small amount helps us go a long way. We also are very interested in people who want to volunteer. So if you have passion or experience with anything, whether it's developing programming, contributing to research efforts, sharing stories, maybe you're just really good at websites and want to help us on our website. Any of those things would be greatly appreciated. I'll leave it at that. Some of our handles are there if you'd like to follow. So I want to thank you for your time. More importantly, though, I need to thank the army of volunteers that we have. This is the heart and soul of the Emotional PPE Project. Our over 700 therapists, I couldn't fit them all on the slide, obviously, but these are the folks who volunteer to make this possible. All right, So I told you what I was going to tell you. I told you the stuff, and I'm going to tell you what I told you. Physicians have significant mental health needs. The rates of depression, anxiety, PTSD, and suicide are unacceptable. Physicians are unlikely to seek help. And a big reason for that is the unique barriers that are embedded in either career impact, stigma, reluctance to external help, or the logistics. There is a path forward. By the way, there's lots of folks who are contributing to this sort of work. I recommend you check out groups like, obviously, MHA, Therapy Aid, the Lorna Green Foundation. There are a lot. We're not. This is amazing. We're not the only people rowing in this direction. There's a lot of groups to participate in. I would feel just as happy with folks contributing to those organizations as ours. So I think that's what the work that is needed to be done. All right, so with that, I'll pause. I don't think I went over time. We're okay. And then I think we have some time for questions, if that's okay, Jason. Thank you very much. Please. Is there a mic I can pass around, or?
I just need your name. I have a loud voice.
Oh, I'm Dan.
Last name?
Saddawi-Konefka. My mom's from Venezuela, so I got my dad's and my mom's. Yeah.
How would you define mental health?
How would I define mental health?
I give context to that just because, before we used to call it, people think something's wrong with you, or people think, some of the stigma things that you talked about. So how would you define mental health, just on a basic sense?
That's a really good question. No, it's just for me. How would I define mental health? Was the question. I don't know if it's a good definition, but I think I have this picture of a water level, and the tide can go up and down. That's pretty typical. If we're in a drought and the tide's real low and the rocks start to show, there's an issue, and it doesn't mean that you're a bad person. It's just like, hey, we gotta open up the dam and let some water in here. I think it's not really a definition, but it's an image that I have for what it looks like. I think one of the problems that we have in healthcare in general, though, is we tend to define things as the negative divergence, right? It's the illness script. This is why you are below average. So I think right now that's our big problem. Is we got a lot of people who are suffering from these conditions without seeking help. But I think probably a more healthy definition might be recognizing sort of what the typical ups and downs are, and then what the water level is just overall that's cycling around. I suspect you've given some thoughts to that, and other people have too. Does anyone else have a thought on that? Defining mental health. I'll take other questions as well. Thank you, Corey. Yeah.
My question is, has your organization ever been subpoenaed? And if so, do a team of lawyers protect the volunteers in that?
Yeah. So the question was, have we ever been subpoenaed, and do we have lawyers to help us with that? So the therapists who volunteer with us, part of the screening process is making sure that they are licensed in the state and so forth. It's sort of terms of engagement, I guess, are that these physicians and nurses and respiratory therapists and EMTs all sort of come into their practice under their typical practice terms. So sort of a nice positive benefit of not collecting any individual information and not if you go onto the site, it's really just you pick your state. There are some filters if you want a man, if you want a woman, if you want someone in a particular demographic, but otherwise it's just there's their contact information and you reach out to them. So we do that to help. The primary reason for that was to help with make people feel safe with care. But a nice positive externality of that is that it does keep the organization, kind of free of that sort of thing. Yeah. Thank you.
How much of the stigma is a part of the career? Like, you go to med school and you know it's going to be rigorous, right? And I guess that some of the mental health issues, I would say, probably start in medical school. So my question is, do you think you lose efficiency by implementing and trying to take away some of the stress and the mental health conditions that some of the students or residents might feel?
Let me paraphrase your question and make sure I've understood it correctly. Are there costs to providing good mental health for physicians? In other words, if things become too loose or supportive, do we?
Is there a loss in?
Yeah. What's the flip side? What do we lose? Yeah, I think that's a good question, and I like it because it's sort of counter the frame, right? I actually don't see them as mutually exclusive. I think there are issues with physician and nursing workforce. About 1 in 5 healthcare workers left their careers during COVID. So that's an issue, and if we now propose that there's additional time away for receiving care and all these other things, is that going to further hurt that, or do we lose efficiency? But I think the long-term gains are substantially greater. I think that not only that, but I actually don't think they're totally mutually exclusive. So I see a psychiatrist once a month, and that hour that I spend makes the hundreds of other hours that I have substantially more efficient. So I don't think they have to be mutually exclusive. Although it's a really good point that you raised, that almost nothing we do in life is all upside, right? Yes?
So I have 2 questions. I love the direction that you're going in because I feel like it is needed with the first responders. So what is your marketing to get that kind of like that information out there to know, for people to even know that it's out here?
Yeah. How do we try to get awareness of these sort of things? It's a little bit challenging, and the main things that we have done include social media and then traditional media. So we have a pretty large Instagram following. There's some on Twitter as well. We've also written a bunch of op-eds, so it goes out with different society newsletters. One that I think flashed up there was a piece that we put in the Dallas Medical Journal, but it's imperfect in terms of getting people access to the directory. I worry about that a little bit less for the specific work that we're doing for research and advocacy. Not because I don't want to get the word out there, but because we're not like an ego-driven organization. Like if people get that information from us, great. If they get that information from one of the other folks, Lorna Green Foundation, for example, I think has a very, very large footprint in this space. I think that's also great. I guess the third thing we do is talks like this.
One more question.
Please.
You had a lot of forward thinking of saying that you're going to change the way the application is, and there were other things you're going to do to kind of help with that stigma. what is your plan to actually, will there ever be any kind of training where you go into the, hospitals and be able to actually help them with learning different self-care techniques? Is that ever a plan for, or do you already do it?
Yeah, so we haven't done that to any great extent. I really, it's just been at the local level, so me with my trainees and our board members with their groups. We do have workshop materials in development. The idea there would be that maybe just in terms of return on time, taking those to national, what are they called, meetings, and holding workshops there, so we hit a number of institutions at the same time. But if we can expand our volunteer base sufficiently, then I'd love to arm them with the tools and just go forth and use. Thank you. It's a really good question. Please.
From somebody that's on this side, like the mental health side of things, it seems like there's a disconnect, and it's odd that, to me, it's right in the name, right? Mental health. And if the objective is, right, everybody wants a physician who's healthy, right? If your mental health is lacking, then you're not healthy. So what do you think needs to be done or can be done to see the two things, physical health and mental health as like equally important? Because there's so much research that proves that, stress, mental health conditions directly lead to physical issues and diseases and chronic illnesses. So what do you think can be done to see them as equal?
That's such a beautiful question. The question was, this isn't exactly what you said, but hey, by talking about mental health as mental health, we're actually stigmatizing it. Why aren't we just talking about health in general? And I couldn't agree more. I think some of the recommendations that we've given to folks who work with boards is don't ask about mental and physical health. In fact, to be honest, go a step further, don't even ask about health, just ask about fitness for duty. Can you actually do the things you need to do? But I think the reason it ends up getting attention is because physical health tends to be less stigmatized. If you have a physician with severe diabetes versus a physician with severe depression, people unfortunately see those differently, even if they're both well controlled. So it's this tough challenge of how do we bring attention to the part that we're talking about, and sort of take the risk of further stigmatizing it as something different. But you're 100% right. We need to just talk about. We need to push for the day where maybe instead of Mental Health America, it's just Health America, right? Thank you. I think I'm maybe just past my time. Is this okay? Okay. Please.
Are you faithful to any diversity by providing these free programs to physicians compared to traditional organizations like government organizations that have already been in place for years?
I'm so sorry. I lost parts of it.
Is this organization facing any adversity from different traditional or government organizations that have been in place for years by providing this free care to healthcare professionals?
Oh, is there like a backlash?
Yeah.
Honestly, not yet. I think we're kind of in a time in society these days, especially coming out of the pandemic, where mental and emotional care, not just for healthcare professionals, but just everywhere, it's just gotten so much more attention. We haven't gotten a lot of hate yet, but maybe that's just because we're not that big yet. Yeah.
I was wondering if you have a political portion or components to what you do with regards to reaching out to state officials. Like, we have advocacy days in Delaware, and I was wondering if you approach your mission in terms of a political perspective.
The question was, do we have a political arm in terms of advocating for change, legislative change, those sorts of things? So we don't currently have anyone on the board who has that as an area of expertise. What we've done instead is work through sort of the network of allies that we have to arm them with the data. So for example, when the JAMA paper came out, we did a big press release, and we partnered with Corey Feist. He's the president of the Lorna Breen Foundation. For context, the Lorna Breen Healthcare Heroes Act was, I think that's what it's called, was signed into law in March last year, and it's pushing for a lot of the changes that we're talking about here. Corey does a lot of presenting and sort of providing testimony to inform these sort of laws. So partnering with groups like that, we have some other extenders who are they work closely with governors in their states and those things, but we haven't, not because of lack of want necessarily, but just because it's been working okay. If you or if anyone happens to have a passion for that sort of thing, we would love to involve you. We actually just put out a call for board member expansion. Our next board meeting is tonight at 7:30 p.m. So we'll be talking about the applications that we've gotten. If you go to either the Instagram or the Twitter page there, you can actually see the call for applications. If this is your thing. Yes?
I know you had talked about like physicians being trained and going to schools, experiencing this as well. Is this something like mental health and self-care, something that's taught in med school, and while students are going through programs to like get it before to get out into the world of practice?
That's where the money is. So the question was, is this something that's taught about in schools at an early level and going forward so that it becomes sort of just like the normal thing? The answer is increasingly, but still only to a small degree. So I think I went to a fairly progressive medical school, University of Michigan. I don't recall this was in the aughts, but I don't recall that being a big part of the curriculum. I think that is what needs to be done, though. I have heard of some training programs actually having as the default is quarterly sessions, and you can opt out, but it's actually the normal thing to do is seeking help. I actually kind of like that frame. We do that in other places in medicine. When you get to a certain age, you go for your colonoscopy, not because you're a bad person, but because you're at risk of colon cancer. And I think entering healthcare, gosh, you could expand this to many different populations, you become at risk. So we're not trying to single you out, but it's what we see as normal. So that's this third arm here, this partnering with training programs. I think that is where, I think that is the best path to changing the future. It means that we won't see the effect of it for 30 years or so until people were sort of brought up with this being the typical. So that's okay, I'm patient. And in the meantime, we can do other things.
From my experience, like substance abuse and mental health go hand in hand, right?
I'm so sorry.
From my experience, like substance abuse and mental health can go hand in hand, right? If a physician is suffering from substance abuse also, like you'll offer guidance in that.
Yes, that is, so the question was, there's overlap between substance use and mental health conditions. If you want to talk about stigma, substance use gets, I think, even more stigmatized. There are some things that tend to make institutions more wary about that because of the easy access to substances that a lot of folks have. the training program that I look after is an anesthesiology training program. If you look at anesthesiologists across the country, it's about 1% will actually end up with a substance use issue at some point in their career. We have, at our place, we actually started it in 2002 or 3. Anyone, it's not because you're a bad person, it's because you're at risk. So we do this with our nurse anesthetists, our faculty, our residents. You have access to these substances and you're at risk. We do random urine drug screens. And if there's a positive, again, it's not this is a let's find the bad person and weed them out. It's, oh, there's actually a lot of things that we can do to help you. And this program was started at my hospital, and there's a colleague of mine, his name's Mike Fitzsimons. He's gone around and shown a lot of other places how to do this. I think it's becoming more and more normal in anesthesiology. To shorten and answer your question though, are there resources for that? Absolutely. I think, I really didn't touch on it today. I do think the stigma is substantially greater for substance use than it is for mental health. If you have a chance to watch Dr. Levitz's video, she actually talks about her history of issues with substance use as well. Thank you. Great question. Perfect. Thank you all so very much. Feel free to